All right. Thank you all for joining. My name is Kaylee Sadoff with the American Heart Association. Welcome to our webinar series today. And I want to give a little bit of a background as to why we put this series together, and then I'll introduce our speakers for the day. In 2024, the American Heart Association received a grant from the Centers for Disease Control and Prevention for projects that will increase education and awareness of heart valve disease. The foundation of this grant was the CAREL Act and the Cardiovascular Advances in Research and Opportunities Legacy Act, which was signed into law in 2022. The association has invested in heart valve disease through multiple initiatives and has increasingly focused on opportunities further upstream of intervention. This grant in particular allows us to engage at the earliest opportunity for identification, the primary care setting. Through this work, we've collaborated with external organizations to broaden dissemination of initiative resources, supported scalable efforts through 15 valve centers nationwide who are working with referring providers, and developed new resources to expand our reach and impact across the heart valve patient ecosystem. As a part of our healthcare professional education efforts, our cohort of valve centers has developed this comprehensive webinar series focused on key topics across the valve disease patient journey. Building on the first two webinars, our third and final session today will review when to refer, shared decision making, and different treatment pathways for patients in heart valve disease. I'm going to go to the next slide, please. A few housekeeping things before we introduce our speakers today. Everyone is muted, but we do encourage you to use the Q&A panel at the bottom of your screen. So we will pause a couple times for questions and then review those at the end as well. On. This is approved for 1 continuing education credit. Next slide. Next slide. All right, you can see disclosures here, and I will leave it there while I introduce our speakers today. Dr. Perpetua is a nurse practitioner, affiliate assistant professor at University of Washington School of Nursing, and the founder of Empath Health Services. She's nationally recognized for her passion and expertise in patient-centered, team-based systems of care for valvular, structural, and coronary heart disease. She's also a member of the board of directors of Heart Valve Voice US and the chair of the AHA, American Heart Association, Heart Valve Initiative's Patient Advisory Group. Dr. Perpetua's research focuses heart team care delivery for valvular heart disease and shared decision-making and team-based cardiovascular care. With Dr. Perpetua, we have Dr. Lindman today, who is an associate professor of medicine and medical director of the Structural Heart and Valve Center in the Division of Cardiovascular Medicine at Vanderbilt. His clinical areas of expertise are heart valve disease and echocardiography. Dr. Lindman's research is focused on calcific aortic stenosis, and he plays a leadership role in the American Heart Association's Target Aortic Stenosis Initiative. With that, I will hand it over to our presenters today, and I'll be back to answer any questions.
All right, thank you, Kaylee. Pleasure to join for this webinar today, and delighted to do this with Liz, my good friend. We know each other well for many years, and so these are conversations that we'll have today that we have oftentimes, and now we're just doing this in a more formal setting. So delighted to be with you, Liz. So here's an outline for the things that we'll cover in this webinar. And again, we do encourage you to submit questions through the chat. First, we're going to talk, mindful of the fact that this is, we presume, primarily a primary care audience of physicians and APPs and nurses. We'll be speaking with that audience particularly in mind. We recognize there may be some cardiologists as well. But want to make clear what referral triggers you might have in mind for sending patients to either general cardiology or to the heart valve team. We want to talk about co-management of valvular heart disease so that you don't just assume that if you refer a patient with heart valve disease, that means somehow that they are necessarily going to get treated when you refer them. That's not necessarily the case. And then talk a bit about, take the veil, up, so to speak, in terms of what is this multidisciplinary heart valve team? What is shared decision making? What is the information they're looking at, the diagnostic testing they're doing? What's a window into those conversations? We'll hopefully provide some insight on that today. And that may be largely through some of our discussion on number 4, some of the treatment options available today that are rapidly expanding, and some case studies that we'll discuss. So just first want to give a sense for the magnitude of the prevalence of heart valve disease. Recently there was a publication in JACC, really a landmark publication, presentation. I had the pleasure of being part of this research group that was really primarily at Columbia, and they looked at 3,000 patients or individuals, not necessarily quote-unquote patients, but individuals at most of the states in the United States, and focused on patients 65 or individuals aged 65 to 85. It was diverse and broadly representative, more so than many studies have been done in this space. And they had people go into the homes, obviously with permission and consent, to patients to perform an echocardiogram and ECG. And the point was to really understand from a population, from an epidemiology standpoint, what is the prevalence of moderate or greater valvular heart disease. And the next slide shows that the overall prevalence of moderate or greater valvular heart disease was 8.2% in this group between 65 and 85 years of age. And you can see, as you might expect, that there's a pretty marked increase in the prevalence as the age increases. So you go from 5.1% in the 60s up to almost 15% for people in their early 80s. And perhaps there's a somewhat greater age effect among males than females. And then on the next slide, when we look at the different types of valve disease that were identified, the most common actually was tricuspid regurgitation, perhaps one that we don't focus on as much, but there's some new therapies that make it relevant to think about and consider it. And then the next most prevalent was aortic stenosis at 3.1%. And on the right, you can see some of the relationships between the prevalence of these diseases along the axis of age on the x-axis, and how there is or is not a increase in prevalence as age increases. So I think this is helpful just for you to keep in mind in terms of the fact that there are a lot of patients with significant valvular heart disease. And when they looked and when they made the criteria a little bit looser and included people with mild to moderate and greater, it got close to 20%, so almost 1 in 5 individuals between those ages. So things to keep in mind as you're evaluating patients. Numerous studies have shown that there are some disparities in care in terms of detection and diagnosis and referral and management and treatment. All of those things with respect to women sometimes being under-recognized or recognized later, or not getting quite the same level of testing as males. And then disparities with respect to particularly older individuals, those who, particularly over 80, sometimes less care is obtained in those individuals. And then also differences with respect to race and ethnicity that are probably a combination both of, in some cases, for example, Black individuals, there's some data to suggest that they may have a lower prevalence, for example, of something like aortic stenosis. But there is also evidence of disparities in care related to their, again, Black race in that specific example. So these are things to keep in mind as you're evaluating your patients. And so just to re-emphasize what was stated here with respect to the preview study, 1 in 10 individuals essentially having moderate or worse, probably 1 in 5 individuals having mild to moderate or worse valvular heart disease between the ages of 65 and 85, and it goes even higher if that study had looked at patients over 85, which is an expanding demographic in the United States. That prevalence just continues to increase. And then there's also emerging data from a number of studies pointing to the fact that although our guidelines make very clear that patients, for example, with severe symptomatic aortic stenosis ought to be treated with valve replacement, and data showing that it is clearly life-saving. Up to 50% of patients are not treated who have severe symptomatic aortic stenosis. And if they are treated, some of those patients, it's oftentimes very delayed, which leads to increased morbidity and mortality. So these are sometimes we think, oh, valve disease, maybe it's, it's just valve disease. But the reality is that when you juxtapose it to many cancers, aggressive cancers, the mortality rate for severe valve disease is higher. So these are patients to really keep top of mind and to have timely referral. All right, and then I'll just touch on this classification, and then we'll have a time to maybe address a few questions. So the Valvular Heart Disease Guidelines has outlined stages, much like they've done for heart failure, of patients with valvular heart disease. Stage A is those at risk. Stage B is those with progressive disease, mild or moderate valvular heart disease, and asymptomatic. And then Stage C would be considered asymptomatic severe. And stage C1 is oftentimes those with preserved LV structure and function, whereas C2 tends to be patients who, although they may lack symptoms, have evidence of overt, for example, LV dysfunction. And then stage D is those who are severe and symptomatic. So this is a classification and a staging system to keep in mind as we characterize these patients with valvular heart disease. And Kaylee, you may have some questions for us. I know you're keeping your eye on the chat, and if not, maybe you have some things that could amplify some of the points we've covered.
I'm going to go ahead and read 2 questions here. The first is, what one symptom should prompt consideration for an echocardiogram?
Yeah, so in terms of detection of valvular heart disease, just more broadly, there are really 2 primary means that cause us to raise our antenna and think about getting an echocardiogram, specifically when we're thinking about valve disease. One is auscultation. So routinely we should be listening to the heart, and if we hear a murmur that raises our suspicion for valvular heart disease, that could be a trigger for getting an echo. And then number 2 is, as you're alluding to, Kaylee, patient history and eliciting and ascertaining symptoms that might make us think, maybe valvular heart disease is underlying these symptoms. The reality is that there's not one symptom. I mean, perhaps most commonly, it might be shortness of breath, if I had to say one, and that might be, with varying levels of exertion. But there are other symptoms as well, and oftentimes they're very nonspecific. They're symptoms that could be a number of ED, a number of underlying problems, valvular heart disease being one of them, such as fatigue, or lightheadedness, or feel like I'm going to pass out, or chest pain. I'm thinking here primarily of aortic stenosis type symptoms, but these also apply to many valvular heart diseases. The symptoms of TR, tricuspid regurgitation, oftentimes are more vague and nondescript. So there might be abdominal fullness, or again fatigue, or saying mentioning edema and things of that nature. But one thing that I think it's really important to keep in mind as we think about this patient population that you're all very familiar with is oftentimes it's difficult to elicit these symptoms because patients may not volunteer them, but that may be because they have just subconsciously or consciously restricted their activities because they know that when they do more, they don't feel well. So now they're largely sedentary, and so you ask them if they're short of breath, and they say no, but they're really not doing anything. So I think it can be very helpful, and primary care doctors have an advantage here because these patients longitudinally, so you have context and history. Oftentimes I'm seeing patients in valve clinic, and it's just a second opinion consult, and I have no context. So what they've been doing, and you can ask them explicitly, like, what were you doing 6 months ago, and how might that differ from what you're able to do now? And I think that can be very important. If they have activity trackers and track their steps, you can look at that. There are a lot of ways to try to tease these things out, but don't just assume that when they say, if you ask them how they're feeling and they say fine, like dig and probe for some of these symptoms that really only might come to light if you ask more probing questions.
Great. And Dr. Perpetua, do you have anything you want to add there, or shall I move to the next question?
Perhaps the one thing that I just want to point out, and just to, as Brian had said, we've had a lot of conversations about these topics and questions for quite some time. And as you can see in the slide that he just presented, this stage of valvular heart disease that had historically also then triggered the referral itself was this move from stage C, asymptomatic, to D, symptomatic. And really the component that Brian mentioned about what was the patient or the individual doing 6 months ago versus now, and actually trying to, in the conversations with the patient as well as family, caregivers, care partners, normalize that, it's very common to attribute these changes to something like having more birthdays, aging, something that can be both stealthy and surreptitious, where it can be, even an incentive for me to feel like, oh, I'm just accommodating to having more birthdays because I might be worried as an individual about getting more evaluation or getting more treatment. But normalizing all of that can actually help us to elicit symptoms as well as get the perspectives from the patient's family, caregivers, care partners.
And something Liz said made me just realize to make explicit to you all in terms of triggers for referral. It could be referral to general cardiology, or it could be referral to the heart valve team. And Liz is going to touch on this a bit. But, if someone has moderate disease, I think they should be referred to at least general cardiology. And if it's moderate to severe or severe, you may want to refer directly to the heart valve team to avoid some of the delays that might come from getting something scheduled with cardiology and then getting something scheduled with the multidisciplinary heart valve team. So don't necessarily just think about waiting for symptoms. It could be more triggered based on what you see on the echo.
Thank you. And I think your last statement answered the next question. It was, should we still refer patients who are asymptomatic if their echo reads severe? And I'm not sure if you want to elaborate on that or go ahead and move on.
Certainly, if it says severe, absolutely refer. And, whereas historically there's been more of a dogma and mindset around treating only when patients have severe and symptomatic disease, more and more our guidelines are shifting and the evidence is shifting towards showing the benefit of intervening in patients with severe disease before they develop symptoms. So if the echo is saying severe, absolutely refer. And in that case, I would refer to the multidisciplinary heart valve team and skip, just doing, the general cardiology because treatment may be warranted, imminently.
Yeah, and thank you, Brian. I mean, I really just want to stress this phrase that you introduced, which is the co-management of valvular heart disease. In primary care, you see your patients longitudinally, you know your patients best, and also you will receive, the ongoing care of these patients over time. Whereas us in cardiology or in a valve center, a lot of our care is more episodic. And so it really needs to be nested in this co-management. And so continuing in that same vein that was introduced, what we also want to reframe is that the referral now happening even earlier, say to cardiology for moderate or that stage B valvular heart disease, when that's seen on the echocardiogram already, that referral can happen to cardiology, or if there are symptoms or severe disease directly to a valve center. And either one of those referrals is not a commitment to surgery or transcatheter-based treatment, but it opens up the workup, which is really what is needed so that there's more information to be able to actually have the conversations as to what is the right treatment at the right time. That may be watchful waiting or medical therapy when there's still moderate disease, but really that nuance of being able to understand as these patients transition through these stages and being able to detect that early is best when that co-management is already in place. And so together with the patient and in partnership with primary care, that's really what the multidisciplinary heart team, which I'll talk about a little bit more, that's how we work together to then help determine with the patient the next steps. And that's done in alignment with their goals and what their life looks like. And so we, in cardiology, there have been terms like door to balloon times and just different windows or intervals as thresholds for when we need to ensure there's timely treatment for patients. And now we're just really zooming out to look at what is that early detection and that timely treatment measure for patients with valvular heart disease, and namely something like aortic stenosis, where that analog of a door to balloon time of, say, 90 minutes, is there now a window of early detection or diagnosis to, treatment that could be, 90 days. And so what we're aiming to do is actually prevent these consequences that Brian, Dr. Lindman had mentioned, heart failure, morbidity, mortality, where a lot of that harm is actually, or the risk is actually in the delay to care, which can be, on the front end or as a result of, different throughput or efficiency considerations. So that's why some of this earlier consideration when there's moderate disease and the co-management is now an upstream focus, because that early referral to discuss timing and options for treatment can then preempt that morbidity and mortality and thus preserve the kind of quality of life and function that people want. And so Dr. Lindman had talked about when would we refer to cardiology versus directly to a valve center. And just to kind of, again, make it more explicit and just give, some very clear criteria. General cardiology, earlier, local, if there's a new murmur, moderate valve disease, symptoms that need, a little bit more understanding of how an integrated evaluation with echo, risk factors, exam come together. That's something where cardiology, can start that process. And then that ongoing surveillance of mild to moderate disease can take place, especially if there's comorbid conditions like coronary disease, arrhythmia, or heart failure. And Brian had mentioned really that going directly to the heart valve center is especially what we want to do when there is confirmed or suspected severe valve disease or any asymptomatic severe valve disease. So this is where it's asymptomatic or symptomatic. It's really, is there severe valve disease? And there may also be symptomatic moderate disease that comes with other hemodynamic consequences. And that's something that we also want to ensure that we're seeing those patients in a comprehensive heart valve center sooner and have that partnership with primary care as well as general cardiology. Some of these other aspects that add to complexity, like complex or multi-valve disease, if somebody's had prior cardiac surgery, these are also elements where that co-management and that timely referral directly to the valve center is warranted. And if the patient themselves, or even you as the physician, the provider who knows the patient the best, if there's already a discussion about procedural options, whatever the trigger is, engaging a heart valve center and what that treatment option trajectory and the options may be is also where that referral can be triggered. And when we talk about comprehensive valve centers, really the transcatheter valve therapies that have emerged since about 2011, starting with transcatheter aortic valve replacement, later with transcatheter edge-to-edge repair of the mitral valve, later of the tricuspid valve and other tricuspid valve actual replacements and mitral valve replacements for failed surgical valves. All these different therapies really were driven by policy derived from research studies as well as guidelines that said this is what we need to be able to provide a comprehensive, valve care delivery system for patients with valve disease. And so what that looks like now as these therapies have matured is that as of July of last year, there are 852 sites that have cardiac surgery, transcatheter valve therapies, and a multidisciplinary team as part of what the embedded criteria are to be able to offer these treatments and to offer the evaluation for these treatments. So it's not any longer something that's rare. And, maybe Dr. Lindman, you can add to this, but really it's something that has become more ubiquitous. And there's usually a center, even locally, for the patient to be able to access for being able to access either surgical or transcatheter therapy.
Yeah, I don't have much to add there. This multidisciplinary valve evaluation process and multiple treatment options is now the norm in most locales. Obviously, in the West, with some of the bigger distances, they're less dense, but most patients have access to these options.
Mm-hmm. And the multidisciplinary heart team is really this partnership across the continuum. So what does that look like? Well, our efforts are to really have the patient at the center. And what we call this Tier 1 program is a program that really has all the different evaluation and valve therapies, both surgical, transcatheter, as well as what's in clinical trials and all of the supports, say, mechanical circulatory support and other supportive subspecialty care within the program or the hospital itself. And then the Tier 2 program being a program that has access to some, but not necessarily all of these therapies and the evaluation for them. But the patient being at the center, there's a core team of interprofessional, multidisciplinary experts who evaluate these patients. And that team includes also primary care, because you know your patient the best. And really, we want to ensure that there is this ongoing, continuous, loop of communication and decision-making that happens with the patient at the center. And the multidisciplinary heart team, its composition includes, if you were to say to refer to a heart valve center, that referral would be typically received by a valve clinic nurse coordinator who may work with advanced practice clinicians like an NP or a PA, who then is doing that initial kind of screening and triaging and working together with a valve cardiologist, a cardiac imaging specialist like Dr. Lindman, to be able to then triage and understand what evaluation has been done and what evaluation may still need to be done. And then is an evaluation or consult with an interventional cardiologist and a cardiac surgeon then warranted and then scheduled to be able to then understand what those treatment options may be. And that may be medical therapy, ongoing surveillance, palliative care, transcatheter surgical options. And some of the medical therapy may also be managed with heart failure, as well as that co-management with primary care. A lot of these patients are also older patients, 65 and older. So geriatrician and some of the considerations around sedation for either diagnostic evaluation or the procedures themselves is part of our assessment. And what we're trying to answer are some of the things that Dr. Lindman mentioned earlier, which is, are there symptoms that are attributable to the valve? And there's objective testing, CT angiograms, echocardiograms, when the history is unclear. What's the severity of that disease? And when we look at integrated criteria, an echo plus CAT scan, plus or minus cardiac catheterization to understand what's, maybe driven by ischemic disease. Looking at all of those factors as an integrated whole, not just a single number in isolation, helps us elucidate the severity. And then the timing, as well as the approach. So what is actually aligned for that patient's goals, their risks, their anatomical and functional criteria. And that includes the recovery for any type of procedure that they may undergo. And this is just another way of looking at it. Once that valve disease has been identified in the primary care setting, that referral taking place, really, again, the patient. So being able to start with that values clarification, patient education, that referral from cardiology or directly from primary care to a heart valve center for that evaluative testing. And the goals and the favored treatment with the patient are discussed formally so that medical decision making actually incorporates the patient's goals, values, preferences, and becomes patient-centered shared decision making. So it's not informed consent in isolation. It's really this ongoing conversation, and a final decision is made in consensus with the patient and care partners and the full care team, that primary care physician or provider and the co-management that is there not only for evaluation and treatment, but the follow-up and as we consider lifetime management for that patient. And the point of this particular image is just to show really that the heart team may have experts, but the expert on the patient is the patient. They're the expert on their lived experience, on their condition, what it means to live with these symptoms, what it will mean to recover from any type of procedure, and being able to recognize that at the outset, that there is this partnership. And often that's going to be augmented by your knowledge of the patient. This is what's really kind of a shift in epistemic recognition of where knowledge lies. And so we want to be able to incorporate that knowledge of the patient's experience, their life, their goals into the decision making in the aim of reducing unwarranted and unnecessary care to be able to have optimal care. And that's essential and central to treatment. So really, you've heard me say how the patient goals, and that means independence, travel, family needs, avoiding a nursing facility. Is there a loved one at home they care for with dementia or going through, cancer treatment? All of those things actually are dynamically shaping the recommendation. And of course, anatomical and functional criteria that Dr. Lindman will review in case studies are a core component of that, but it's really looking at the whole. And there are specific educational materials through the American Heart Association, as well as the American College of Cardiology, and decision aids or tools that can help to guide these conversations and start to provide patients, families, and care partners with this kind of input. But it's really primary care that is driving the referral and setting the stage. And for all the reasons that we've discussed, really having that short note on goals or prior preferences, family context, even your assessment as to, how soon this patient needs to be seen. If that's at the top, this patient's had, an ER visit, they've declined a lot in the last, 3 months, they're taking care of, their husband. Appreciate it if they could be seen within the next 30 days. That sort of framing is exceptionally helpful because of the knowledge that you carry about your patients and your expertise.
And to just pick up on that shared decision making aspect, some of these decisions are fairly straightforward. If someone has a severe symptomatic aortic stenosis and they're 76 and now they're short of breath, but they don't have, a lot of life limiting comorbidities, and they're a transfemoral TAVR candidate, there's not a whole lot to discuss. I mean, it's pretty straightforward. But then there are patients who are, either considerably younger, they're 62, and trade-offs of which procedure to do first and whether to do a mechanical or a bioprosthetic valve, and all these things become more complicated. Or some patients who may have some evidence of cognitive impairment, and really wrestling through with them and their family. That's where some of the their goals and priorities and what are they trying to achieve really comes into picture. And that's where that intersects with some of these anatomical things we'll look at. Because if they're a straightforward transfemoral TAVR candidate, that's one thing. If they're not, and you're thinking about alternative access and other complexities to the procedure, that can influence how that conversation goes. So there's a lot of nuance to some of these conversations, whereas others are very straightforward. So this slide is not meant to overwhelm you, but to give you a sense for the innovation that's gone on in the space of valvular heart disease really over the last 20 years. Until 2010, there was only surgical options for aortic stenosis and otherwise. And so those are tried and true, surgical, you have mechanical valves, tissue valves, etc. In the upper left, you see a number of different transcatheter heart valves for treatment of aortic stenosis. And then you see a valve, that JenaValve, which is a first, approved device specifically for aortic regurgitation. And then in the upper right, you see several devices that are available for treating mitral disease. And the MitraClip and the Pascal devices are what we call edge-to-edge repair. We'll show you a picture of those in a moment. Those have been, approved for a while. And then also transcatheter mitral valve replacement options now with, one or two of those approved, several others in clinical trials. There's lots of nuances to these devices, lots of, strengths and weaknesses, pros and cons to these devices in different anatomies. So it's needing to find device anatomy fit. But then in the lower left is really a revolution going on in tricuspid disease. Tricuspid regurgitation for so long has been, what many have referred to as the forgotten valve. And we've just sort of cavalierly been, severe TR, it's fine, they can do all right. But more and more we're seeing that no, it is associated with increased event rates and adverse events of heart failure and death. And so, and surgeons have oftentimes avoided those patients because those patients oftentimes have, whether it's cirrhosis, sick livers, a lot of liver disease and other comorbidities that really increase the risk of a surgical procedure. So now these transcatheter options, edge to edge and replacement, and a lot of variations on those themes are available, and some now FDA approved, which give us treatment options for patients with TR who really haven't had options before. And then there's also options in the pulmonic space as well. So this is to give you a sense that the landscape is vast. The options are numerous. And yes, this is complexity. This is complexity that you don't have to master. You don't need to know these devices by name or their characteristics, but to just recognize that there are numerous options that can treat and help our patients. So this is to just give a brief snapshot to say that in the universe of aortic valve treatment, that the top line is the 106,000 in 2024. 106,000 TAVRs were done, whereas all of the different flavors of surgery totaled to about 67,000. So a much larger number of patients with mostly aortic stenosis here are treated with transcatheter approaches compared to surgery now. And it's approved for patients not only at high risk, but intermediate risk and low risk for surgery. So for really all patients, it's available. You go to the next slide. So this is an animation video showing you a TAVR procedure. This is from Edwards. This is one of the heart valve device companies, and this is a balloon expandable valve. So here you see a sheath that's put in the femoral artery, and now a valve coming up the descending aorta, and this is again a balloon expandable valve. So now they're putting the balloon inside of this crimped stented valve. So it's a metal stent frame and bovine pericardium leaflets that will form the new valve. And so now the device is advanced over the aortic arch. It has that yellow nose cone to allow it to be easier to get across this calcified, thickened, narrow orifice of the aortic valve. And this there's imaging, fluoroscopy to guide the precise placement of where this valve is, and they can make little fine adjustments before they will pace the heart at about 200 beats per minute to drop the cardiac output to nil, and then they will blow up a balloon shortly and expand this crimped valve. And push or squish or the native valve to the side, and now leave this deployed stent. That white material you see there is what we refer to as a skirt to help prevent a paravalvular leak around the valve. and now the device is taken out of the body and the sheath as well. And then I think you'll maybe see in a moment the leaflets now taking over the function of the valve with a nice big orifice there. So this is, we now have data out to about 10 years showing very strong durability of these valves with very low failure rates. So this has really been a transformative innovation for patients with aortic stenosis. So in the mitral space, the mitral repair, the top line is really the total number of mitral repair procedures, surgical and transcatheter, in the United States. And roughly speaking, there's a fairly even breakdown now of surgical mitral valve repair versus transcatheter approaches. A little bit more with surgery, but transcatheter approaches are in the green there, and this is with the edge-to-edge repair is what's considered mitral repair from a transcatheter standpoint. So this is a visual for you of the most commonly done procedure, edge-to-edge repair. On the right, you can see a beating heart. This is a pig with a torn, prolapsing flail leaflet there. You can see the middle scallop of the anterior leaflet on the right, and you can see this edge-to-edge repair device, in this case a MitraClip, pinching, if you will, the anterior leaflet and the posterior leaflets together, cinching them together, and creating making sure that leak is plugged there, and then it creates a figure of 8 orifice that blood then flows through. So this is now very commonly done for patients both with primary and secondary mitral regurgitation. And this is the mitral replacement universe, if you will, where the total number of surgical and transcatheter procedures are roughly similar. There's a lot of different flavors here, so to speak, in terms of what's pointed to with transcatheter therapies. And there are purpose-fit devices for transcatheter mitral valve replacement, but also patients who have had prior surgical mitral valves, they can have a valve-in-valve procedure with a transcatheter valve. So there are a lot of different ways to approach that. So roughly equal there in terms of surgical replacement versus transcatheter approaches. And tricuspid, this is newer in the transcatheter space. So you can see, although the total number of procedures, just for context, there it has tricuspid valve universe 12,000. For context, there are 106,000 TAVRs done in that same year. So, 10 times as many as we're looking at here just for TAVR. So, but here, the yellow line on the bottom is transcatheter tricuspid therapies, and really those are more in their infancy. There are now 2 FDA-approved devices, one edge-to-edge repair and one replacement. And this is, you can see a huge uptick, 3-fold uptick, 4-fold uptick between 23 and 24. So this is a rapidly growing area. And this is a video of the Evoke device. This is transcatheter tricuspid valve replacement, also an Edwards device, the Evoke device. And sometimes edge-to-edge, we might ideally like the edge-to-edge approach just because it avoids anticoagulation, and that's nice, and less risk of a pacemaker. But sometimes, oftentimes, these right-sided annuli are very dilated, and there can be big coaptation gaps, and it can make it difficult to do repair, those edge-to-edge repairs. So this is a replacement. So you see and this is guided by both echo, either TEE or ICE, and fluoroscopy. And so these leaflets are grabbed And then the valve is positioned and gradually deployed, and then it will sort of pinch the leaflets in between and capture them. And then this device will take over the function of the valve. And this can be done even in patients with leads in place and so forth. Those have to be considered and managed and so forth, but that's also an option. So this is fairly recently approved over the last year or so, and we've done a lot at our center and had good experience with that. All right, Liz, you want to take it?
Yeah, thank you. One of the things I also wanted to mention, Brian had said that there's esophageal echocardiographic guidance for the mitral and tricuspid procedures. There may also be some other, imaging like intracardiac echocardiography that is now also used. Most of those patients who undergo mitral TEER, tricuspid TEER, or tricuspid mitral valve replacement, they're often going home within 1 to 2 days. For mitral TEER, it's a bit more of a mature therapy than the other mitral and tricuspid procedures, and those patients are often going home next day. For the TAVR patients, just for this context being the most mature therapy, those procedures are typically done with something that is like monitored anesthesia care, and that involves really no TEE guidance. It's fluoroscopic and guidance, as well as just transthoracic echo. And most of those patients actually just have a peripheral IV, no urinary catheter, and most of those patients are going home the very next day in all age groups, actually. So just wanted to kind of give that context as we enter this case study in an active 82-year-old with severe aortic stenosis. Here, let's imagine that you have an 82-year-old woman that is independent, lives alone, drives. She herself had considered herself too old for treatment, and in agreement with somebody who's independent and strong, most of her care team had said, "Oh, okay, we agree with you because that's what you want." And now she has this change where there's new exertional dyspnea. She is not used to slowing down, and there's also a systolic murmur noted at her annual visit. And so the echo actually confirms what we would call D, stage D, symptomatic severe aortic stenosis with echocardiographic criteria that is often known as classic high gradient aortic stenosis. So these numbers, an aortic valve area of less than 1 and max velocity across the aortic valve of 4.6 meters per second. So very classic high gradient aortic stenosis, person who has symptoms. So the heart team reviews this, does assessment of frailty, understanding, what is her gait speed, what is her strength, what are her activities of daily living. And, she's as functional as, you can imagine, just has this new exertional dyspnea. Her anatomy is favorable for a transfemoral approach, relatively low procedural risk despite her age. And so her goal is really to stay independent, to continue being able to live alone and drive. She wants to be able to keep doing that, really motivated by this goal of seeing her grandchildren. And so after some conversation, TAVR is selected over watchful waiting because of these factors that we've described. And so the decision making, that Brian had mentioned earlier, where it might not be that complicated or preference sensitive, so to say, right? This is kind of an example of where there might be a more obvious treatment, as long as that's something that the patient actually wants for herself. And that's actually what, has been ascertained in that medical decision-making and shared decision-making process. And so the treatment course is transfemoral TAVR under conscious sedation. And then the typical course is a person like this would be ambulating the same day and discharged home the next morning. Oftentimes it's just waiting for the transthoracic echo after the procedure that delays them going home. And she's back to independent living and driving within a couple of weeks. So there is follow-up at 30 days. That is with an echocardiogram and a check on symptoms, and just to understand how that valve is functioning and making sure that there's no, new arrhythmia, that there's no significant paravalvular leak. So what happens when a patient isn't as straightforward? And go ahead, Brian, you wanted to mention, and then I'll show some images.
Yeah, I think just one thing I really want to emphasize, particularly this audience, is that like while we who are familiar with how TAVR works and seeing these patients, don't even blink with the notion of an 82-year-old undergoing this procedure as described, for those who are less familiar with and, used to TAVR as an option, they think of treatment for aortic stenosis as involving this big procedure with lots of risks and open heart and recovery. And like, are we really going to subject an 82-year-old to that? But the landscape has totally changed. And if you have an 82-year-old like this, who, is like, I don't know if I want to fuss with this, and, a procedure, I would say that send them to the heart valve clinic regardless of kind of the reaction. Obviously you can't force them to go, but when we have conversations with these individuals, we're able to just like put it in the context in which it is, and to say, look, yes, it's a procedure. No procedure is risk-free. But, your risk of death or stroke is going to be, probably less than 2%, 2 or 3%, and that's not hyperbole. That's national data. And you're likely going to go home the next day and be about your activities in a week or two. And so when you're able to give that context and that reality check for them, they're like, oh well, okay then. That actually doesn't sound like that big a deal. And it's not in many cases. So it's really, I think, the most informed shared decision-making conversation can occur when they're able to engage with people who can tell them some of these statistics and what to expect and all of that. So just a real encouragement, even if someone, not so sure, just encourage them to go talk to the team. And I think that'll be well worth the time, even if they do decide that they don't want it. So in our next slide, this just gives you a quick snapshot of some of the images we're looking at. You don't need to master any of this, but in the bottom right, you see the CT scans that are done, and we can do CT-FFR to see if there are any blocked coronaries to be concerned about as we're thinking about treatment for the valve. In the bottom left, we're looking at the femoral and iliac and aortic access for a transfemoral TAVR, which most people can accommodate, over 95%. And then in the top, and again, this is all CT. CT has been transformative in terms of our understanding of how to evaluate patients and risk and anatomy and so forth. So in the upper left, you see one that's a bicuspid valve with a very calcified RAF-A, between, let's say at 10:30 if you're looking at a clock. And that would be something that if someone is 65 and they have that and they're otherwise low risk for surgery, we would say, Mr. Smith, you might want to do TAVR, we get it, but we really recommend surgery because you're at risk for potential aortic rupture, a paravalvular leak, and you're otherwise low risk for surgery. And then that middle one, maybe it's bicuspid, maybe there's a little fusing there, but it's not as much of a calcified RAF-A. So, if it's someone who's, 75 and really wants TAVR, no problem. This would not cause us to stop in our tracks. And then on the right, upper right, it shows you that the calcified annuli can sometimes create issues with paravalvular leak, and to be considerate of that. So I'm mindful of our time, so maybe we could go on to some mitral cases. This is someone who, just focused your attention in the lower left, is someone who has moderate bileaflet mitral valve prolapse. So this is someone with primary mitral regurgitation. They have a normal EF, which you see in the upper left, and they have severe mitral regurgitation. And so this is someone who, let's say they're 82 and they're, intermediate, or if they're higher risk for surgery, they could be a candidate for transcatheter edge-to-edge repair. And so I think in our next slide, we'll see some pictures. Well, this is just some causes of primary MR. Maybe we could skip forward. And here you can see on the right the TEE showing a flail posterior leaflet, P2 scallop. You see that showing up on the nice echo images on the left. And I'm not sure if we'll see so this would be someone who a clip, they'd be a really great candidate for a clip, put right in the center there. And the next one is just secondary MR. These are patients with typically a dilated ventricle, and the leaflets are tethered, and there's resulting regurgitation. And COAPT and other studies have shown us that treatment with transcatheter edge-to-edge repair improves survival and rehospitalization. And so they would be good candidates for that. And there are other therapies if they're not good candidates for edge-to-edge repair. So this is just showing you as, you can see on the right, a very dilated spherical left ventricle, dysfunctional with resulting regurgitation that could be a candidate for transcatheter therapy. So this, I'll perhaps just, speak fairly quickly to. A lot of times patients that we see with mitral regurgitation also have substantial tricuspid regurgitation, and this is one such patient. And one of the nice things about transcatheter options is it allows us to treat one valve lesion and see if the other one gets better, because we don't necessarily have to do it at the same time like a surgical approach. So particularly in these patients, particularly with secondary MR, of a dilated left ventricle, and they may have pulmonary hypertension, and the right side's affected, and they have concomitant tricuspid regurgitation. After we've optimized them on guideline-directed medical therapy and done cardiac resynchronization, all important things for secondary MR, if we treat with transcatheter edge-to-edge therapy and then sometimes are even able to further optimize their medical therapy, sometimes that tricuspid regurgitation will substantially diminish or go away, and we won't need to intervene on the right side. But there can be decision-making around, and this is where the nuances and details matter. Is it primary? Is it secondary? What's their age? What's their surgical risk? Is there concomitant atrial fibrillation that we could do a surgical maze on? There's a lot of different options, but these are the types of discussions that we have as a multidisciplinary heart valve team, integrating imaging and risk and age and patient goals and preferences.
And as we conclude, we just want to leave us with these key take-home messages. And, Dr. Lindman had discussed referring moderate valve disease early to cardiology, moderate to severe valve disease to a valve center, and watchful waiting can occur even when there's moderate disease with valvular heart disease co-management. And secondly, this referral focus is evaluation and management of a disease. So we evaluate the patient who's being referred for aortic stenosis. They're not being referred for TAVR or being referred for surgery. That determination gets to be made together based on the evaluation. And that co-management includes primary care and that early referral with this awareness of the referral triggers that, hopefully we've been able to make more explicit and more just approachable. And your expertise, your understanding of your patient, the symptoms, function, goals, that is so highly valuable for shared decision-making downstream and also for our triage upstream. And then lastly, we also want to introduce this keeping your index of suspicion kind of high across patients, because there's little to no downside in ensuring that they have the information, that you have the information to understand what would be appropriate timing, what is early diagnosis, what is early treatment, and then having that right treatment at the right time, and understanding that that suspicion is also in place because presentations can differ. That mitral and tricuspid concomitant disease can kind of sit in a clinic for years, and that presentation the patient may be very comfortable with. So it's not one size fits all, and introducing this possibility of referral sooner than later may actually preempt decline, morbidity or mortality.
All right. Well, it's been a pleasure to do this webinar with you, Liz, and have this conversation. I realize we didn't get as much to the chat, but hopefully we preempted and addressed some of the questions that arose there, and maybe you can close us out, Kaylee.
Thank you so much. Thank you both for presenting this excellent curriculum, having that robust discussion. We would also like to extend our gratitude to our participants for registering and joining today's session. You'll receive an email with a link to claim your continuing education credit after this event. And if you should have any trouble, there's also an AHA contact on that message. So thank you both again, and that will close us out for the day.
Thank you.
Thank you.